Shekar, nice to meet you. Thank you for coming.
Same here. It's a pleasure.
You are from India?
Yes,
Shekar,
yes, I'm from India.
You are working with children.
Yes, I'm a pediatric dentist by profession.
Very interesting, yes.
Since the last 12 years, I'm into laser dentistry also.
Very interesting, yes.
My field of specialization revolves around the use of lasers in children as well as in cancer patients and patients of TMT or alopecia pain. We run an exclusive children's practice. I teach children's dentistry at the Rajiv Gandhi University of Health Sciences, Bangalore, India. And we have an exclusive clinic for TMJ and orofacial pain, one exclusive clinic for oral mucositis with the regional cancer center there. So that's basically
it's very huge. It's very huge. So maybe you can talk about your daily workflow. You do with
twice a week. I am expected to attend to my postgraduate students at the university. So usually my Tuesdays, Thursdays, and sometimes my Saturdays are spent with my postgraduate students. The remaining days, it starts around 10:30 in the morning, and it revolves around seeing a lot of cancer patients. We get a lot of referrals from various cancer centers around my place. Some patients travel as much as 400 to 600 kilometers to see me for one session of PBM. Devastating cases of oral mucositis. They are diagnosed at various stages of cancer. They undergo chemotherapy, radiation. Unfortunately, that message about prophylactic PBM to prevent mucositis is still not very clear with the Indian doctors as such.
How do you use laser therapy for prevention?
If we go by the recent ESMO guidelines, European Society for Medical Oncology, it's been proved that photobiomodulation has radioprotective and chemoprotective effects. So by energizing the cells, we are preparing them to better face the onslaught of radiation or chemotherapy.
How do you use laser therapy with these patients in your daily workflow?
What I do is that we have a team of doctors working for us. If the patient is non-ambulatory, if the patient is admitted in the cancer center, we have our portable units. We prefer working with the red wavelength for our mucositis cases. Although we have the luxury of having 7 wavelengths under one roof at our hospital, starting from a blood irrigation 660 to a 2940 RBMI. We have got 7 wavelengths, and we have certain portable units which can be shifted to the bedside of the patient if they are non-ambulatory, if they are on chemotherapy or radiation. Yes. If they are able to walk down, then we have a nice little clinic with a beach as a mural, so that it makes a little bit of a difference to their painful life. Like I was mentioning yesterday, we cannot add days to their life, but we can certainly add more life to their remaining days.
Okay, of course, yes. To make it
that
better.
is how I think we can make a difference to the lives of those cancer patients who have already gone through so much of pain and suffering. So we encourage them to walk down, maybe have a cup of coffee with us, and then attend a session of PBM with some nice music in the background. This is my way of doing this a little bit for their painful lives. Otherwise, they get they're claustrophobic in that hospital environment. They see disease everywhere, they see pain everywhere. So they have to come out of that. Right? And it is as much as mental as it is physical.
Yes.
In fact, of late I've started trying auricular acupuncture on the Shenman point with PBM for these patients. They seem to feel better, their mood is lighter. They are more vibrant. They
increase the quality.
Yes.
Increase the
quality of their thing. Their pain threshold increases.
Yeah. How do you use it? Just you with children?
It's actually very easy using it with children. To be very honest. Generally, people think that lasers and children don't go well with each other. That's not so true. In fact, in our practice, there children enjoy lasers. We tell them that we'll make you a rock star. Give them protective eyewears, and they see that in the mirror. They're excited. And then my child patients ask me today, what today? Red, blue? What light today? They're excited.
Great. Yes. It's a game.
It's a game for
them.
It's a game for
You are teaching laser therapy at university.
I am basically a postgraduate teacher of pediatric dentistry. I'm a professor at Rajiv Gandhi University of Health Sciences. I've got 3 postdoctoral students under me, and I make it a point that their master's thesis for their degree revolves around some work involving photobiomodulation and or laser therapy in children.
Correct. But it's not involved in the education system of
unfortunately, no, because lasers are still not a mainframe of our curriculum. But I make it a point that all my pediatric dentistry postdoctoral students get to work on lasers. Their master's thesis has to be something related to photobiomodulation. We've been doing that for close to 6-7 years now.
So just even in India, you start to integrate it in universities?
Yes. But we have a little bit of constraints when it comes to infrastructure. Not all the colleges or universities are willing to invest so much on multiple wavelengths. So we need to rely on certain academies. I also work with the Asian Academy of Laser Therapy. I am their India mentor. So most of my postdoctoral students sometimes have to go to the academy to complete their thesis, especially when it involves an all-tissue laser or when multiple wavelengths are needed to complete their study. We do a lot of work on photodynamic therapy in pediatric endodontics. We do a lot of work on photobiomodulation in children. So we are moving towards multi-wavelength therapy. So it's not enough if we have 1 wavelength or 2 wavelengths at one given college or university. We need multiple wavelengths.
Of course.
So that's where we are heading to. We are now planning a study on acceleration of orthodontic tooth movement in children. We want to have a split mouth wherein we try the red on one side and the infrared on the other side and see exactly how it works on accelerating orthodontic tooth movement in children. Exciting field.
Very exciting field. How do we get in touch to make it for the dentists around your clinic?
What we do is that through this academy we conduct regular continuing dental education programs, something like a continuing medical education.
Is an interesting, are they interested?
They are, as long as it is done on a weekend and it does not disturb their practice and it is offered at a minimal fee, they are more than willing to attend. And some of them, surprisingly, are so interested in it that they want to pursue and take it to the next level. They come down for our fellowship programs from the academy. They first get initiated into it by a one-day course, and they get so excited that they wish to,
Need more.
Yes, they need more.
Great.
That's how we, sort of generate that interest.
Very interesting, yes. Now it's increasing, just even not by a dentist. What's the other fields? What do you think with physical doctors? Is it integrated also in India?
Yes, that's one advantage of this particular academy with which I work with. This is not the Asian Academy of Laser Dentistry. This is the Asian Academy of Laser Therapy. So they have dermatologists on the board, they have physiotherapists on the board, and they work with a lot of physicians and a lot of dentists, of course. So, we are able to integrate that because ultimately we believe that the light has to reach the masses.
Yes.
The message has to spread.
Yes. What do you think? Laser therapy is very cheap. You only need one investigation of some stuff, and then it's very cheap. Is it a problem for India because?
Yeah, maybe yes, to some extent, because we have to look at non-coherent sources of light.
Yeah.
When we have to take the affordability factor into equation, then yes, non-coherent sources of light, I believe, are the way forward for a country like India. We can't expect Indian dentist or an Indian physician to invest 5 to 6 lakh rupees on, on a class 4 or on a, dedicated laser equipment, because their practice revolves around multiple things and not just specifically related to lasers. So I think it's a better thing to to move towards LEDs and non-coherent sources of light, so that the patients still get the benefit and the doctors are happy because they're not investing much on the particular equipment.
What do you think the next step? What is the next step after laser technique?
Sorry?
What is the next step after laser technique? How could you? What is the future?
Future will revolve around having fostering partnerships between us and our caregivers as well as the patients, because home care lasers are going to play a huge role in future. Because typically, if we talk about mucositis, how often can I expect my cancer patient to come and see me?
Yeah.
Twice a week, thrice a week. So if I can give them a home care device, not necessarily a laser, again an LED, which he can probably clip it at the corner of his mouth, maybe a 660. I've just bought one now. You know, I'm so excited to see that here. Yes, it's. I mean, they can afford that. When they can afford lakhs of rupees on the chemotherapy and radiation, might as well pay 15,000-20,000 rupees more on you know, having a home care device that will make their life simple, and it will you know, I feel the future is going to be having a synergistic work with our patients, wherein we do the in-office laser therapy and then rely on them for the home care as well.
So you see the future is a self-therapy?
Not exactly a substitute for laser therapists, but yes, in partnership with laser therapy. Suppose if I have a case of a complicated mucositis, if I see the patient twice a week, I expect him to follow up on my instructions at home on the remaining 4 days at least. That is how it is going to work, is what I feel.
Shekar, I think in all over the world diabetes is increasing.
Yes.
And not just even in Germany, just even in India, I think you have really problems.
Exactly.
And how do you integrate this problem with the big field of laser therapy?
Yeah. Actually, the problem is worse in a developing country like India. It's actually worse. And there was a recent survey which said that by 2025, India will be the diabetes capital of the world.
Really?
Yeah. By 2025, we will be the diabetes capital of the world. That's a sad part of the story, because we are burdening the healthcare system. And once the patient is diagnosed as having type 2 diabetes, he or she has to rely on either oral antidiabetics or insulin for the rest of their life. That's an economic burden too, and the healthcare system is not matured enough to take care of that kind of a burden. So the best way forward is to prevent it. And of late, studies have linked diabetes with the oral health status of the patient. Because we have come across several cross-sectional studies wherein the HbA1c, that is the glycosylated hemoglobin levels of a particular patient, fall down by almost 2 units by after 3 months of simple oral prophylaxis. So what we are doing now is that we are having this chain of clinics called Laser Smiles, wherein we work with a diabetologist or a physician. We have a small operatory in their hospital, and every patient has to mandatorily undergo an oral prophylaxis, a laser-assisted photodynamic therapy if needed for their periodontal pockets, and then they go for their dose revision with the diabetologist. They don't do it blindly.
Right.
So that is the link that we are trying to establish between the systemic health and the oral health, and there again photobiomodulation and photodynamic therapy is helping us. We don't have to rely on a periodontist. A general dentist who's trained in lasers can do a good job with prophylaxis and use certain photosensitizers and do a photodynamic therapy. It doesn't need very complicated infrastructure, and it can be integrated in a diabetes setup. In a diabetes setup.
In a normal dental clinic.
Dental clinic,
right.
Yeah.
It's very easy. How is the impact of nutrition?
Very, very important, because as we know, the microcirculation is compromised, and the cells are not getting enough nutrition when the systemic health is hampered. So there again, you know, the way forward is that we have to work with diabetologists, we have to work with nutritional specialists and you know, dietitians, so that the patient gets a holistic approach to their problem, and rather than compartmentalizing things.
So you have the 3 steps: nutrition and
lasers, oral lasers, and the physician modulating in between. We are working with diabetic foot surgeons also. You know, we salvage a foot indicated for amputation by doing photobiomodulation. Excellent results. So we are now planning to take it to the next step. We are planning to use this PRP, platelet-rich plasma, as a bandage for the wound, and then doing PBM. That's next thing on the lines.
Because of results.
Yes. There are a lot of growth factors there.
Great. Yeah. Good idea. Very good idea. Another question. I think pain is an international problem.
Yes.
TMG is, I think, the problem of the future.
Yes.
Stress is going up.
How
do you use for TMG just laser techniques?
Yeah. Actually, what happens is that majority of these TMG patients in our country go to the ENT specialist, and the ENT specialist first tries treating the ear of the patient, thinking that there is some problem with the ear. So it's after 2 or 3 months that they seem to have lost the way, and they feel, no, nothing is happening. There is no infection in the ear. The middle ear cavity is fine. So what else could be the problem? That is how they get referred to us. And since I have had my experience with ICNOG, with a little bit of, you are yourself a very accomplished neuromuscular dentist, so you understand, how difficult it is for us to see that kind of a patient, diagnose it early, and then start the therapy as early as possible. So we're trying to spread this message amongst those ENT surgeons that when they suspect a pathology beyond the ear, kindly refer those cases to us. We have a diagnostic setup where we do a TMJ scan, open mouth, closed mouth. We understand the health of the condylar region, the disc, as well as the retrodiscal space as to what exactly is happening. And then we start multivalent therapy depending on whether it's a myogenic type of TMD or an arthrogenic type of TMD or a combined arthro-myo kind of a TMD. If it's only an arthrogenic kind of a TMD where we lead a limited penetration, we stick to the red wavelength. And if it's a myogenic, muscles are involved, we need a deeper penetration of the wavelength, then we go for a near infrared. And majority of these cases are unfortunately youngsters these days. India is the IT capital of the world. They work for what, 8 to 10 hours a day, totally stressed. They go back home, they brush their teeth at night. The occlusal wear facets, 30-35-year-olds with devastated dentition. They come with temporomandibular joint dysfunction at that stage, and majority of them have internal disc derangement also. So from that stage onwards, we try to reduce the inflammation in the joints. We try to regenerate the condylar articular surfaces as well as the joint fluid, and then once the patient is stabilized, we refer him to a prosthodontist for the occlusal rehab or a neuromuscular orthodontist for the correction, for the long-term maintenance of the corrected result.
Thank you so much. It
Pleasure.
was very interesting.
Pleasure being here, Doctor.
Hope to see you next year.
Yeah, same here.